Before we do the end, Michael, there were three subjects that we did not bring up. That we
Do you think it was purposeful?
Yes, because I wanted to do it at the end. The three new subjects, okay, that we talked about in the beginning of our introduction: palliative care, physician-assisted suicide, and option 3. They are referenced in this book. We will be doing a much more great. Well, we'll be doing another book, so it'll be in detail. Which one would you like to start with?
I think we should start with palliative care because
Okay.
a lot of people have a misunderstanding of what palliative care is, and I work in a palliative care service, and so I want to make sure that we get clear about what palliative care is and what it isn't. One of the things that frequently is said is hospice is palliative care. Well, hospice is a form of palliative care. I call it the end stage version of palliative care. So it is a form of palliative care, but it is really about the end stage process. People can actually receive palliative care at diagnosis. And palliative care is going to focus on the stuff that happens to people, the symptoms that get out of control, pain, anxiety, depression, shortness of breath, things of that nature.
Nausea, vomiting.
All that stuff that basically, when you're going through aggressive or active treatment, you still may have these symptoms that need to be addressed.
Okay, now did you hear him? While you're still going through active treatment, they do not take your treatment away from you under palliative care.
And a lot of times I have said to people, gosh, you know what, it really sounds like you would benefit from palliative care. And I've had patients say to me, but I'm not dying. And the reality is that, hang on a second. I don't know if that'll show up in the video or not, but it might. One of the things that's most important to understand is that palliative care can start way in advance. Hospice is end stage, and it really is about that point where you are no longer treating aggressively and that you really just need symptom management and comfort-focused care. And that's really hospice. But the truth of the matter is that a lot of patients really could benefit from palliative care, and because they have this thought in their head that it's about dying, they choose not to have it. And I want you to know, it's not just you. It's your physician too. And it's the people in our lives that don't understand the difference. And there's a reason that they don't understand it, is because there are hospice programs that have that in their name, hospice and palliative care. So they have that.
Or palliative care hospice.
Well, they have it linked.
Yeah.
And it's linked. It's linked within their name, the name of their program. And so I always am having to remind people that no, palliative care is done way before and can be done at the time of diagnosis. And it's really a focus on symptom management while you're treating your condition.
Right. Well, Michael, the important thing about that is that if you've got a long-term chronic problem, ALS, Huntington's,
cystic
fibrosis, Parkinson's disease, cancers, multiple bouts of cancers, you need palliative care right at the beginning, right up front.
It's very important to have that person who is skilled in palliative care be involved in your care, because they're going to make suggestions and offer you choices that basically you wouldn't get offered unless the person who is working with you understands the difference.
Correct. I would love to see palliative care standing on its own, removed from hospice, with language and other things, but right now, that's not going to happen.
No, it's not.
It's not realistic. But my preference as a patient would be to have them totally separate.
Well, a lot of times we talk about calling it something different, and I sometimes I bristle on that, because it doesn't really matter what we call it.
No.
There's always going to be that position, that a physician who is in the position of offering that to you is going to say, you know what, it's just like hospice. You're not ready for hospice. And so that frustrates me, because that happens almost daily, where a physician will say to a patient who's asking and saying, I need palliative care, the physician will say, you're not ready for that.
Right.
You're not dying. And that just reinforces the position that palliative care is hospice, and it's not.
Well, Richard and I have a very good friend who was just diagnosed end stage and offered palliative care. and the situation that he's in, I want to know why he wasn't offered that 5 years ago or a year ago, minimally. But they wait too long, and that's been an ongoing problem that we hope to address with these blogs and with our book, because by educating the patient's going to start demanding services because they'll be conscious of them.
They will drive this discussion.
They will drive.
And that is really my goal. My
Yes.
goal is to have the patient and the family drive this discussion, because physicians will then begin to understand it's different.
Different, exactly. And we got tired of trying to educate one patient at a time.
Mm-hmm.
We would like to be able to set up scenarios where we get a couple of hundred at a time that need this information and could benefit from it. So we're not going to talk about physician-assisted suicide.
Well, the state of California passed 2 years ago a law that basically put into place a process whereby a seriously ill, terminally ill individual could basically make a request for physician aid in dying. And basically the process is outlined in quite a bit of detail.
Yeah.
And that if you want to participate in this, you have to have made a request for it, and then you have to make the request again in 2 weeks. You have to fill out some paperwork.
Mm-hmm.
A physician has to be able to
Mm-hmm.
write and certify that you're terminally ill, and then a physician has to write the prescription for you to receive. And then you have to have the pharmacy fill the prescription, and then you have to have someone help.
You have to be able to open up all the capsules and take it yourself. But legally, nobody can help you.
Right.
Now, that doesn't mean people aren't helping other patients, but legally, the language is such that...
Right now, this is something that is available in 5 states, 6 states. There's a number of countries where this is available.
Yes.
But the reality is that I believe that they made this so complex and so difficult to do. One, to get it passed, and to get it passed in the state of California was not an easy process, and the way that it passed wasn't necessarily the way that one should make laws. But the reality is that it does have a sunset provision in it that basically they can make some adjustments to it, so that we start to look at really what it is that the person is asking for. I personally want to make sure that we understand that someone asking for physician assistance in dying really is suffering, and so somebody needs to do a better job of assessment of suffering of that individual, because people suffer on multiple levels. People suffer from a physical standpoint, from an emotional standpoint, and a spiritual standpoint.
Yes.
So the reality is that if we can address those things, people may have less of a need for physician aid in dying. The reason I say physician aid in dying is
it drives me crazy.
They don't want to call it suicide.
Yeah.
And actually, that was one of the things that the law did, is that the law basically made it so that if you followed the process, that suicide would not be listed on your death certificate.
Yeah.
The underlying disease process, what you were dying from, would be the cause of death.
But the law states physician-assisted suicide. It does not do medical aid in dying.
I know.
Yes. So
I'm aware of that.
There's a even between us, there's a contradiction, and we need to have the contradictions, and we need to have the discussion. Because one of the things that Michael and I talk about under the suicide chapter is there's all kinds of suicides. You can quit taking your medication. You can quit eating. You don't have to jump off a bridge and blow your brains out or try to get physician-assisted suicide. You can just decide to take yourself off the planet any way you want to. A variety of ways.
One of the things when this was in the process of being passed, and there was lots of stuff going on in Sacramento. I had people who said, "This is my right,"
Mm-hmm.
and I would say to them, "You've always had the right to kill
Mm-hmm.
yourself, but now you're asking me to participate in that
Right.
as a taxpayer and as another citizen in the state of California."
And I may not agree with your
and-
right to do that.
And I have a problem with state-sanctioned or state-supported suicide. Mostly because I think that once you let the genie out of the bottle, you have got all sorts of problems that come along with that. And we're seeing that today because, one, there's not a lot of physicians who are willing to assist in this process, and there's not a lot of process in the process.
Yes, exactly.
Because what happens is the people who ask for this don't always get what they want because they're too far along.
Mm-hmm. Yes, they've waited too long.
A lot of times patients
or
that bring this up,
their family members will come in and say, why wasn't this offered to us? Well, you have to ask.
Right. You have to ask because in all honesty, I'm not going to bring it up to somebody.
Well, you legally can't, Michael.
Right. I don't know whether it's legal or not legal, but the reality is that I've had families who've said, "Why didn't you bring this up?"
Right, exactly.
And I've said to them, "How was I supposed to know that this was something that you needed to know about?" Well, you should be giving all of the options. And
you should know.
Yeah. Well, the truth of the matter is that, I mean, it's clear in the conversation, I'm not necessarily a supporter of this.
Yeah.
And I don't have a problem saying that because I believe that what we're doing is we're failing to treat suffering.
Yes.
And if we did a better job of treating suffering, we wouldn't even need to have this conversation.
Right. But we do.